Today we're going to look at Standard 3 of the 2014 standards. So looking at our summary slide, the 6 standards again, focusing today on population health management. You can see there that there's 5 elements, with element D being the must-pass element. And so again, an extra element than Standard 2 that we looked at last week. So 5 total elements, but what you'll see with a lot of these elements and factors within this standard is there's less policy and process documentation and more of our use with meta and reports as the documentation, not so much the policies and procedures. Getting started looking at the standard population health management, the intent being that the practice uses a comprehensive health assessment and evidence-based decision support based on complete patient information and clinical data to manage the health of its entire population. So again, the 5 elements stated there, you can see, and on the right-hand side, the alignment with meaningful use. So again, a lot of areas here that align with meaningful use and where those reports are sufficient documentation with the same thresholds and time requirements. Element A, patient information. You can see here the list of factors, looking at that the practice is using the electronic system to record this patient information. So factors 1 through 13 as structured searchable data for more than 80% of its patients. And then factor 14 at the bottom, the name and contact information of other healthcare professionals involved in the patient's care. So obviously looking that there's a record of all the different places and providers that are giving this patient care. The first 5 factors you can see there is where the meaningful use alignment comes in. Keeping in mind for this element, the important thing is with the documentation is not leaving any searchable fields blank, as well as other things that programs and different things that you report on. Obviously, you want to make sure that anywhere that there is an option to put that information in that you are. And also keeping in mind that different options counting towards the numerator for these percentages. So if the patient declined, if they don't have, say, for example, an email address, noting that there is none, not just leaving that blank. A couple different things to point out for some of these. Again, for factor number 5, preferred language, this is another area where a blank field doesn't just defaultly mean that their preferred language is English, putting in whether they refused or if you're not sure, but not leaving that blank. Again, for telephone numbers, email addresses, recording none if the patient doesn't have one. Using the occupation field as a place to note if it's a retired patient, if they're disabled, unemployed, if they're a student. Providing this information gives a good background on things for health risks and social determinants of health that the standard focuses on, and we'll see in later elements where that information becomes important. For number 9, the dates of previous clinical visits, this is any of your encounters, so whether it be your face-to-face office visits, electronic visits, scheduled phone appointments, any of those alternative clinical encounters, anything that's a scheduled appointment, having all of that dated and in the patient record. Factor 11, the primary caregiver. This is not looking at the primary care provider. This is who gives day-to-day care for the patient. So if it's an elderly patient, it could be their child, that is their primary caregiver. It could be a spouse, a parent, whoever is that day-to-day care provider for the patient. For factor 14, this can be collected in, obviously, in the patient chart in their care plan. It doesn't have to be searchable or structured data, just captured in the patient's record. So the scoring and documentation requirements, you can see there it's worth 3 points with a minimum of 10 of the factors to get the full 100 points. And for the documentation, again, they're looking for more than 80% of patients have each of those factors, factors 1 through 13, in their record. And you can see there the numerator, denominator, and percent that they're looking for. And for factor 14, a documented process for capturing the data for the different providers of care, and 3 examples demonstrating the implementation of the process. So your screenshots of where that is in the patient's record or how you capture that data or obtain that data. The note on the bottom there, you'll see that I added that NTQA is not looking for the individualized patient data records with the reports, just looking for the percentage with the numerator and denominator for each report. So here you can see example. This obviously does have all of the patient records with the patient information obviously blanked out. But you can see here for this report, this looks at all factors 1 through 13 and gives you your percent at the bottom of where you're at with a yes or no, yes indicating that that information is in the patient's record. And the far right-hand column showing you how many of these different factors are in for each patient. And one thing I forgot to mention and falls into place here is the not applicable options for pediatric sites. So factor 8, occupation, is suitable for pediatric sites to respond with NA, and also for factor 12, the presence of advanced directives. Those 2 areas, pediatric sites, NA for your response. And another example, just capturing here in a patient's record of where you can see their other providers of care, their whole care team, and just an example screenshot of that. Keeping in mind for this example, like I mentioned, they're looking for a documented process in 3 examples. So along with this one screenshot, you would also need to show 2 other examples and the documented process. And again, noting obviously in the upper left that the patient information has been removed. Moving on to element B, clinical data. Again, you can see here that every factor has an alignment with meaningful use. So again, a lot of reports for the documentation. And this looking at the practice is using the electronic system with the functionality in factors 6 and 7 and records the information in the other factors, again, as structured searchable data. So you can see there, again, the thresholds and the different things that they're looking for there in the patient's record, up-to-date problem list for more than 80%, allergies for more than 80%, blood pressure, height and length, weight. Looking, again, how they mentioned 6 and 7, the functionality that the system can calculate and display BMI, and then also plot and display the growth charts. Status of tobacco use, the list of prescription meds, and more than 20% of patients having family history recorded as structured data, and the final factor being at least 1 electronic progress note created, edited, and signed by eligible professional for more than 30% of the patients. Looking at factors 3 through 5, this is an area where this could be one document. Your vitals can show just in one report these 3 different factors if you meet them for the more than 80%. I think the rest of these are pretty straightforward and self-explanatory. For factor 11, this is looking for something that's text searchable, so any searchable notes that do not, any non-text notes do not meet the intent for that factor, so that's what they're looking for there. But again, as you see, a lot of these align with meaningful use, so a lot of these reports will be able to just be generated from that. The scoring is a possible of 4 points and with a minimum of 9 factors to meet the 100% for this. And on the right-hand side, the documentation for factors 1 through 5 and 8 through 11 are those reports showing the percent of all the patients for the populated field. Again, that's for at least 3 months of data within the past 12 months. In factors 6 and 7, looking at the functionality, the screenshot demonstrating that the system can calculate and display BMI and also plot and display the growth charts and BMI percentile. Here's another report example, so not looking at different reports other than straight from meaningful use. This one capturing all of the factors and the percent that they're currently meeting at the bottom. And a look at the functionality and another screenshot of looking at the plotting and displaying of the growth charts and BMI percentile. So this is meeting factor 7. And again, there you can see that this is within the age that they're looking for and showing the functionality and the ability to plot this and show the percentile. So element C is looking at comprehensive health assessment. So looking at understanding the health risks and information needs of the patients, and that the practice collects and regularly updates a health assessment, including the following factors. Factor 1, the age and gender appropriate immunizations and screenings. So looking at your mammograms, colonoscopies, that these are updated and that the practice is regularly looking at these different lists. Factor 2, family, social, cultural characteristics, looking at the patient's different education levels, occupation, if it's a single parent household, if it's a married, divorced, widowed patient. So this is where the information that I had mentioned back in element A could give a little bit more information as far as their occupation or a little bit more about the needs of the patient. Factor 3, communication needs. You see they're noted, not language. So this is looking at hearing needs, their reading ability, any comprehension issues, anything that they need to assist them with communicating about their care. Factor 4, medical history of the patient and family. Again, this is another area where it could be documented as unknown, so that there's something in there if that's the case. Factor 5, advanced care planning, again, NA for pediatric sites. Factor 6, behaviors affecting health. So this is looking at possibly their oral health and dental care, secondhand smoke exposure, risky sexual behaviors, their diet, anything of their behavior that it could be affecting their health. Factor 7, mental health and substance use history of patient and family. So any history of depression, illegal drug use, stress, alcohol abuse. Factor 8, developmental screening using a standardized tool. Again, here you can see NA for practices with no pediatric patients. Factor 9, depression screening for adults and adolescents using a standardized tool. And Factor 10, the assessment of health literacy. So does the patient need a caregiver to follow through with their treatment? This is obviously something that you want to look at when considering different care plans and discussing and assessing with the patient what they understand and what they need to follow through with their treatment. So this is one area where the practice determines how frequently they update the health assessment. So again, it's not, NCQA isn't stating that it has to be assessed every 3 months, every year, every 6 months. This is up to the practice. And also keeping in mind using this to consider how these assessments help establish the criteria that are going to support the practice's process for identifying their care management patients. So that is something that we're going to get into in the next webinar, digging into that care management piece and creating those registries of patients that are going to benefit for care management. So keeping in mind how this leads into this and helps set some criteria to establish those lists. The scoring for this gets into one of the workbooks that NCQA provides. So you can see 4 possible points again with 8 factors to reach 100%. And then the documentation, you'll see that there's an option for how this is documented. So for factors 1 through 10, it could be a system-generated report, again, with the numerator and denominator. And the report there clearly indicating how many patients had an assessment for each factor, and that data was entered in the medical record for more than 50% in order for the practice to respond yes to the factor. Or there you can see option 2. Review patient records selected for the medical record review as required in elements 4, B, and C, and document presence or absence of the information in the record review workbook. And also keeping in mind, once I explain the workbook a little bit more, that if this is the option that was used, also examples are required to show how each factor is documented. And then again at the bottom, factors 8 and 9, in addition to the report above, the practice must provide a completed form for each factor. So factor 8 being your developmental screening tool and factor 9 being the depression screening tool. So the workbook that NCQA provides is an Excel document that could be used for this element, element 3C, and also for elements 4B and 4C, which again gets into care management. And it's their way of keeping track of these patients and looking at what is recorded in their record. So this example slide is a screenshot of what the review workbook looks like. You can see that I added there that they're looking to you to report on 30 patients. This is, you can see here in the orange, 3C, looking at this element, comprehensive health assessment. 1 through 10, each different factor had its own column. And then within each cell is a drop-down list of either yes or no, if that specific factor is included for that patient. There's some instances where either NA or not used is an option. But then again, on the right-hand side in the green box, you can see that that's where it starts 4B for care planning and self-care. And again, they do that the same with each column being a different factor. So you would, for all 3 of these elements, if they were being reported this way, we would be looking at all the same 30 patients that whatever criteria the office decides on, 30 patients that they think will benefit from care management, and then looking across those patients for these 3 elements. And I'll provide some information specifically on the workbook and show you the instructions. There is a 2-page instruction sheet that they provide with the workbook that explains inputting the information and that it calculates everything for you. The next slide is just some information that I provided as some optional suggestions if this is something that helps to remember or to document these different things in the patient's record. So on the left-hand side, you can see that they provide this as a checklist to be used during every visit with a patient selected for care management tracking. So you create your registry of patients for care management, and keeping this as a guide that whenever you're visiting with them, that you remember to check those items that are properly documented in the medical record, so that when you're going to report, those are areas that you can report yes, and then of course have a higher percentage of those that you have recorded. Again, not something that's required, not something that needs to be reported or submitted to NCQA for recognition, just something there as a guide if it helps. On the right-hand side, measures selection strategies. This is just looking at, again, I've shared this before, showing the connection between different elements and how looking at 3D, which we're looking at next, relates to element 6A, which we'll be looking at obviously in a few weeks. That 7 different measures can be used for both of those. They're looking at the same different criteria, so using the same ones obviously, so that you're not reporting on 14 different measures, you're just looking at 7. So that's just something that you could read through and see where these different elements come together, and where showing that these aren't just, again, individual factors and elements that stand alone, that they all come together to create this care for the patient and this flow for the office all together. So element 3D, the use of data for population management, obviously, as you can see, the must-pass element for this standard. And this is your proactive reminders. This is using either mail, email, phone, direct encounters, whether it be when the patient is in the office or you speak to them one-on-one, giving those proactive reminders for various services. At least annually, the practice proactively identifies populations of patients and reminds them or their family of needed care based on patient information, clinical data, health assessments, and evidence-based guidelines, including, and then you can see there the 5 factors included here, and the first 3 aligning again with meaningful use requirements. Factor 1, at least 2 different preventative care services. So this isn't your immunizations or assessments. These are 2 different preventative care services. So looking at well child visits, pediatric screenings, stress tests, mammograms, fasting, blood sugar, any 2 different preventative care services. Factor 2, at least 2 different immunizations. So this isn't the same immunization for 2 different age groups. It has to be 2 separate immunizations. Factor 3, at least 3 different chronic or acute care services. And to keep in mind that this can be 3 different services from the same condition. So it's not saying that you have to look at 3 different conditions and a service for each. It could be 3 from the same condition. And factors 1, 2, and 3 are the same 7 measures. So 2 preventative, 2 immunizations, 3 chronic or acute. Those same different measures are what element 6A is going to be looking for, but within that element they're looking for a measuring of the clinical quality and the performance. So that's where we're getting into PQRS reporting. But I just wanted to show you that it's the same measures for these 3 factors that are then in 6A. Factor 4, patients not recently seen by practice. And factor 5, medication monitoring or alert. So this is looking at a list of patients on a specific medication. It could be used for if they were prescribed the brand name and there's a generic available, if there's any type of recall or warnings for a specific medication. So looking at lists of patients on a specific medication for whatever reason that may be. So because of the number of different services and actions that they're looking for, again, 2 in factor 1, 2 in factor 2, 3 in factor 3, and then 1 each for factor 4 and 5, this element does have the potential of having 9 different reports needed. So you can see the scoring, again, a must-pass element, 5 points possible, 2 factors needed to pass this element to be able to receive any type of recognition level, and 4 factors to get to the 100% scoring. On the right, the documentation. So for all the factors, a report or list of patients needing services generated within the previous 12 months, and also materials showing how the patients were notified for each service. And again, keeping in mind that obviously those materials have to be proactive and reaching out to the patient in a way that is showing that you're looking at these lists and telling them that they are overdue or in need of these services. The 2 boxes on the left-hand side are just some information of showing you how the meaningful use criteria fits into these different factors. And with any areas of PCMH, obviously keeping in mind if you're reporting PQRS measures, or again, anything obviously with meaningful use, trying to coordinate that so that we could report more easily and so that you're focusing on the same conditions that would be then improved for your quality outcomes. So examples, this is just looking at a list generated of patients needing chronic care service, and on the bottom, the example of the materials for how this list of patients was contacted. Last element, element 3E, implementing evidence-based decision support. So from 3D that we just looked at and the different measures that will be reported, for this element, thinking to select clinical guidelines for the conditions chosen in 3D would probably be helpful and easiest to provide. So practice implements clinical decision support following evidence-based guidelines for following 6 factors. Factor 1 being the critical factor, a mental health or substance use disorder. Again, the critical factor indicating the emphasis that they're putting on including behavioral health and mental health into the standards. So depression, anxiety, ADD, dementia, bipolar disorder, alcoholism. Factor 2, a chronic medical condition. Factor 3, acute condition. 4, a condition related to unhealthy behaviors. Factor 5, well child or adult care. And factor 6, overuse, inappropriate issues. So your use of antibiotics, avoiding unnecessary testing, and again, seeing the alignment there with all of the factors and meaningful use requirements. The scoring, again, 4 points possible, needing to include factor 1, your mental health or substance use, to receive 75% or higher for your scoring. And the documentation for all 6 factors, looking at the conditions that the practice identified for each factor, the source of the guidelines used by the practice, and then examples of the guideline implementation. And you can see there some of the different examples that they offer, whether it be flow sheets or templates, again, coming from the EMR, and keeping in mind that all 3 of those different things are required for each factor. So obviously identifying the condition and then the source of the guidelines and examples of implementation. And just noting there, in some of the examples that I'm going to show, there's citations or links to where the guidelines came from, but simply stating, as mentioned there, based upon the American Heart Association recommendations, that is sufficient enough as far as providing the source of the guidelines. This page has a lot of information on it. It's just kind of pulled from different examples and different templates. The upper left box, just looking at different criteria for selection, obviously looking at different things that are already being reported and those that are important to the practice. For factor 2, looking at an example of where you can see they obviously stated the condition there as being diabetes, and based on the recommendations from the American Diabetes Association and the following guidelines for that, so showing their source. And this one would need, again with it, the implementation. So that's just meeting 2 of the 3 requirements for the documentation. And then on the right-hand side, 3 different examples, again showing the condition and the source, and would need to show implementation. This slide, I believe, is not included in the one that I sent out. I think I included it afterwards. But just, again, some more conditions or different things for when you're selecting these conditions, and where 3D and 3E work together, come together, are looking for the same types of things. So as I mentioned, picking and reporting, obviously, the evidence-based guidelines, the clinical decision support with those services that you report for 3D. At this point, does anyone have any questions? Okay, then we're just going to take a look at the last slide, which again is just some information, some tips to keep in mind as you're creating policies and procedures. Again, in this standard, we saw that a lot of the documentation requirements are reports or examples and not so much the actual written policies that we see in other standards. But just wanted to pull out a few of these things to keep in mind. The first one being, obviously, in creating these documents or revising ones that the office already has, we want to do so to meet the requirements to receive recognition. But keeping in mind that these really need to be beneficial and for the practice, for the staff. So writing it for them to understand and follow while still meeting the requirements for recognition. The second paragraph there mentions making the policies and procedures specific and measurable. So NCQA obviously keeps things a little bit broad in their requirements and allows the office to define what their different time frames or feedback times are. So using specific numbers, areas of response when creating these policies. And again, a good way to assess the different policies and procedures is to imagine a temporary worker or a new employee, or simply asking someone to look at these, and would the person be able to understand what is expected, how things work, how things operate within the office by just reading through these policies. The third tip, NCQA assesses 2 aspects of the policies and procedures. So the first being whether or not the practice has instituted an indicated policy, so whether you have that in place, and whether or not the staff adhere to its specifications. So again, they allow you to define time frames, and they're not looking to judge or score you on what that is for you. So if your policy states that a patient's phone call will be responded to within 1 hour, they're not scoring you by saying, oh, I think that should be a half hour. It's just looking that you have something in place and that meets their requirements, and that the staff is working to meet those specifications and standards. And the fourth one down there to keep in mind, to be approved by NCQA, policies and procedures must be signed by the practice leadership and implemented. So again, policies and procedures in place, implemented for at least 3 months before submission. And obviously, staff should be trained on the policies and procedures, so everyone should know their roles and what's expected and how things operate as far as these guidelines and policies. So once again, if anyone has any questions, I have unmuted everyone, or you can send a message in the chat box. If you think of anything later, obviously send me an email. But if we don't have any questions, then we can end here. And thank you again for listening and for taking the time out this morning, and hope everyone has a good weekend.
Thank you, Rachel.
Thank you, Rachel. You're welcome.